Welcome to the Scale Healthcare Technology and Innovation Podcast, where we explore how innovative technology is revolutionizing U.S. healthcare. Hosted by Jason Schiffman, President of Scale, we sit down with industry leaders to uncover the strategies, breakthroughs, and technologies shaping the future of care. Join us and subscribe as we dive into the cutting edge of healthcare innovation.
All right, welcome to the next episode of the Scale Community Healthcare Technology and Innovation Podcast. And I'm pleased to be joined this morning by Tim Attebery, CEO of Cardiovascular Associates of America, CVA USA. CVA is a leading national cardiovascular MSO with a network of more than 160 locations, more than 550 providers, serving more than 1 million active patients across 8 states. And so welcome, Tim. Good to have you today.
Thank you. Good to see you, Jason.
So I've had the pleasure of hearing the story of CVA USA a few times now through our conversations, and you were also a guest at our conference last year. And there's a lot that stands out. We have a lot of guests on this podcast that are technology players that are innovating through bringing new technologies to the MSO market. I think CVA USA is an example of what I would call structural innovation. And you've built a network that really advances patient care in many different ways. And I think there's a lot of lessons that we can learn from that, from the broader MSO market. And so we'll cover a few things that stand out. But the first thing that stands out to me is there are some overarching themes that are priorities in the MSO market. And I think CVA USA touches on pretty much every single one of them. And so, I'm going to list a few at the opening because I think we'll return to these throughout the conversation. But how to operate a risk-based model within a specialty care environment, how to grow and differentiate through strategic partnerships, how to effectively deploy technology into advanced care delivery, how to navigate through the decisions and questions around buy versus build versus partner when you're aiming to build something truly comprehensive within a reasonable amount of time, how to expand patient access and optimize the cost of care by building a diversified site of service portfolio ranging from virtual to home care to ASC, and how to be a true leader in the market and take a stand on what leadership means and what you stand for as a business and promote it loudly and proudly in the market. And so those are the key things that have stood out to me as I've had a chance to hear the story, and I'm super excited to cover each of those points through this conversation. So maybe that's a good way to tee up from your perspective, Tim. Maybe you can give us an overview of what you've built at CVA USA since the company was founded about 4 years ago in 2021.
Sure. Yeah, we officially started December 17th, 2021 with our first partnership group, and I was employee number 1, launching the endeavor in September of 2021. So just quickly, my background, I've been in healthcare a long time. I'm an old guy, Jason. I've been in healthcare since '86, most of it in the cardiovascular space. So I've built a lot of strong expertise and background in cardiology. And I was recovering from a life-threatening illness in 2021, thinking about, all right, looks like I'm going to live through this illness and going to be able to get back on the field. Hallelujah. And I started looking at what has happened to this profession called cardiology and to the delivery of cardiovascular care in this country. And what can we do to address what I saw to be some fundamental, big, dangerous problems? Fundamental problem number 1, the profession was slowly getting commoditized by becoming hospital employed. And my little joke is 80% of cardiologists are hospital employed, which means 80% of cardiologists are somewhere on the misery index, low, moderate, or high. So that was my first concern is, God, if we're not careful, this profession is going to get wiped out. It's just going to become hospital commoditized. Number 2, because of baby boomers, I'm one of them, and the increasing incidence and prevalence of the disease and people living longer post initial diagnosis of some form of the disease, this is a growing problem for the economy. Medicare, I'm a taxpayer. I don't want to have my taxes go up. So what can we do to get better control of delivering care in a more efficient and effective manner? And I started looking at these elements, and I won't go into all of it, but it struck me that the one thing we could do that would satisfy the problems that as I was seeing is we need to protect and celebrate and empower entrepreneurial cardiology, the profession of cardiology where smart cardiologists are in a foxhole, and they're in a foxhole realizing that they need to manage 2 things well. They need to deliver clinical quality care, high quality care in a very effective and efficient way. But they also have to make sure that they're managing the resources that go along with that and the total cost of care in a very efficient and effective way, while at the same time making sure the patient experience and access and equity, et cetera, are all protected. And that led me to conclude that to do that, we needed a capital partner to support the investments that it would take to empower cardiovascular specialists to transform patient care. And that is our mission at CVA USA. Very simple, to empower who? The cardiovascular specialists to do what? To transform patient care, how it's delivered, how it's reimbursed. With the thesis being this, that a lot of what we call cardiovascular care spending, which is roughly $300 billion a year in the US, a big chunk of that, I think it's somewhere around 30% of it, is avoidable. $90 billion avoidable spending. By the way, that is almost 2 times as much as what's paid to cardiologists for delivering the care. So we're paying the cardiologists to manage and deliver care, the professional side, but then the hospitals and pharma and everything else gets paid. If we could incentivize the physicians properly, the cardiologists, and equip them with the resources they need, data, clinical decision support tools, wraparound services, et cetera, they could lead the effort to transform the way cardiovascular care is delivered in the US and simultaneously transform the way cardiovascular care is reimbursed. So that at the end of that, we have entrepreneurial physicians leading the charge, not the government, not the insurance companies, not the hospitals. And those same physicians in the foxhole understand that they are economically benefiting only if they do 2 things well. Again, good clinical management and efficient use of resources, bringing the trend line of the total cost of care down. If we create that home for entrepreneurial cardiologists, that home will empower the physicians to achieve this grand goal. And it's happening right now here at CVA USA 3 years and a few months later.
So what you mentioned home, you're creating this home. And I think at a high level, the goal of high quality, low cost care, the goal of avoiding avoidable healthcare expense, those are common goals. What's unique about the home that you've built at CVA USA? What are some rooms in the home that you've taken a lot of care that you think are particularly special, differentiated? Is it, you mentioned data analytics, is it home care? And what does it look like under the hood and inside the home?
So I think the first thing is we have to clinically, operationally, financially, legally, culturally integrate. There has to be that integration. The physicians across the CVA USA network must believe each day they come to work, each time they are interacting with patients, that part of their income is tied to the success of the enterprise. The success of the enterprise is tied to not just fee-for-service, volume-based performance. It's also the quality, the safety, and the efficiency. The first is you got to have the integration. And I think part of what we've done is we've created one common platform. So even though it's multiple groups, it's one common platform. Every physician owns part of CVA USA. Part of their financial benefit comes from the value of that equity of the enterprise building up. So we've got the heart. You got to have the heart, you got to have the head, got to have the body. But if you don't have the heart, you don't have the emotional connection, the passionate connection, doesn't work. So we've got that. Secondly, we know that it takes capital to help each of our partner groups expand and develop their markets locally to create better access points, whether it's physical access points or virtual access points, and expand the services that it takes so that we can have ambulatory surgery centers as alternative sites of care to the hospital. So we've invested in the infrastructure. We've invested in data analytics. We've invested in imaging, ASC, all the things that require a high amount of capital upfront before they start to pay off. We need to leverage APPs, advanced practice providers. Most of our groups have some form of utilization of APPs, but not at the highest level. So we've created a very focused effort to help all of our groups optimize their investment in APPs. And I won't get into all the details of that, but the APP plays a central role in delivering and transforming care, because the cardiologist needs to work on the things that only the cardiologist's brain and ability can focus on. The APP empowers us to have effectively more capacity to provide better care. Then we need to wrap around all of that investment in ASCs and advanced imaging and new office locations and new physicians and new APPs and expanded access point. We need to wrap around all of that with clinical data analytics and the ability to integrate clinical data, both discrete data and flat files, natural language processing, and push back to our groups, to our physicians, scorecards and performance information about how well the groups are doing overall and how well each individual provider is doing, each individual physician is doing. So the data analytics component, which is a multi-million-dollar endeavor that also connects with revenue cycle management and your practice management systems, we've invested in that. That's another room in the house. Another big room in the house is value-based care and risk-based contracting. And for the first time, even though there have been pieces of this and maybe some small success stories in the last 20 years, we believe that we have set a new standard. We have cardiologists contracting with traditional payers and risk-bearing organizations for populations and episodes where we lose money if we don't manage those episodes efficiently. We're just crazy enough at CVA USA that we will contract with a risk-bearing organization and we promise to save them money. And if we don't save them money, we guarantee that savings. Now that will make you wake up each morning and realize we've got to come through. That's real. We're really guaranteeing a savings. Each doc knows that part of their income and part of their wealth and equity of CVA USA is tied to that. So these payer contracts that we've developed, and now we have around 30,000 lives under management, where those 30,000 lives are patients of ours. They're not new patients. They're our patients that we've shifted from a traditional fee-for-service only to a blend of fee-for-service and value-based, risk-based contracting. That muscle is slowly developing inside of CVA USA. It's an important muscle. We want all of our clinicians to have great clinical abilities and great resource management capabilities. And to do that, the only way I know to do it, human nature being what it is, you got to have what's in it for me. What's in it for me? And the what's in it for me is I either take a pay cut or I can make more money if I deliver. So the value-based care and risk-based contracting, important element. Our Nova Cardio merger in April of 2023 was instrumental. CVA USA was only about a couple of years old at that point, year and a half old. And we merged with Nova Cardia. We brought in all those beautiful, rich Nova Cardia assets that were all around data analytics, care model development, contracting. We brought those in, and that took us maybe several years forward in one fell swoop. And part of what we brought in was some smart people, Dan Blumenthal, Catherine Evans, who had already envisioned the care model. What is the care model? Because you have to have a contracting model on one side and a care model on the other side. Otherwise, you're taking risk and you don't have a way to operationalize it. The care model is the operational capability. Third thing then we've done is we know that cardiology care cannot all be face-to-face with the patient. It's impossible. Patients won't do it. Patients can't do it. We don't have the physical capacity to do it. We need to have virtual care. So we stood up a command center in July that is expanding from mobile cardiac telemetry to remote physiologic monitoring to implantable EP devices monitoring, and we'll have more utility. That's a touch point that we now have a 24/7 staff that work for CVA USA that support our 27 partner groups. We launched home-based cardiac rehab in fall of last year. We have about 100,000 patients of our 1.2 million patients that can benefit from phase 2 cardiac rehab. The vast majority of them don't get it. Why? Because phase 2 cardiac rehab requires people to drive 36 times to a facility for 36 sessions over 12 weeks. Only 6% of Americans who qualify for cardiac and who need cardiac rehab complete it because it's too big a hurdle to drive and do all those sessions. So we developed a solution, and now we have home-based cardiac rehab. And we have other solutions that we're developing, cardiac urgent care, after-hours care, physical, that patients can come in instead of going to the ED that we're rolling out. So all of it is about what? Physician leaders driving the change, driving the transformation. So we have great physician leadership. We equip and empower those leaders. We wrap around various services and solutions to accelerate their ability to manage populations and episodes, and do that with a financial incentive that if we can lower the cost of care, lower than the trend line, we benefit and the payer benefits, the patients benefit. And it's all being done with the physicians leading the charge.
What I think is so interesting is you just described an incredibly complex ecosystem. So on the reimbursement side, you're talking about risk-based, reimbursement care, which is complex and risky inherently. And then on the care delivery side, you're talking about innovative sites of service in the ASC and the high-risk home care. You're talking about investment in the telemetry division of your business. So there's a lot there. You're extending well beyond your traditional cardiology practice. And yet the business model is very simple. And it's really focused on what does it take to deliver great cardiology care, and what are the services required to do that holistically. And it sounds like you found a way to build a pretty comprehensive, complex ecosystem while staying grounded to a pretty core, reliable business principle of keeping, you mentioned the providers at the center, but I would also argue the patients at the center. What equals excellent care? The question I have as a follow-up listening to all that is you have clearly found a way to incorporate experimentation and innovation into your business model. And with that comes the spoils. There's a lot of rewards for being a leader in the market. There's a lot of rewards, even financially, in a risk-based model if you do it well. But with experimentation also comes risk. How much of what you described is experimentation versus fairly certain initiatives and outcomes? And how have you balanced stability with experimentation as you've gone through building out CVA USA?
Yeah, so it's a great question, and I can't say that we've mastered it, Jason. So I don't think I'm ready for the podium to describe the mastery of this, but I can tell you we're experimenting still with how to do exactly what you said. Here's the good news. We have 27 groups that were formerly independent groups. So that culture of independence is still strong, which I love. That's a thing of beauty. It's not a bad thing. It's a good thing. As a result, some groups choose on their own, just organically, kind of a natural experiment. We want to try something. We are getting better at curating this and documenting this. Sometimes it's happening and we find out about it when the lab blows up and something didn't work so well. We still want to know that. All right, they tried X, X didn't work. Let's get the word out to everybody. Don't do X. It didn't work. So we can have that cross-pollination. But the communication interaction between our physician leaders and our business leaders is very strong now. We're at a solid point where people are exchanging. There's no embarrassment now. There's transparency across the network. These aren't competitors. These are people that are collaborating. So now we've created a forum, an innovation committee that does nothing but looking at all the things that are happening and documenting that, creating the library. Who are the partners? What are the experiments? What are the key metrics we want to look at to see if it works? And in some cases, we're having simultaneous experiments on the same area, but with two different potential partners, with two different solutions. Now we can run an experiment. Which one works better? And from that, the innovation committee and the physician leaders and business leaders can exchange best practice. So we're encouraging the natural experimentation. We're encouraging partners who come to us. A lot of times this will happen, Jason. We'll get a call from a potential solution provider saying, we want to work with all CVA USA. We say, no, that's not what we're going to do. You're going to work with one group, maybe a group that has been looking for this solution, that could be a good host, a good laboratory. Let's find that laboratory for you. If it works, 6 months or a year later, we look back and say it's working, or we tweaked it and made it work, then we make that a solution. Much like the old Toyota tight, loose, tight strategy for lean. There are tight policies, there are loose policies that each Toyota plant can experiment. Then if it works, you go back to tight. We're getting into that groove. Recent example of that, sorry to ramble, but a recent example of that is Hybrid Chart. Hybrid Chart is a solution out of Arizona. One of our cardiologist leaders actually founded the company. We experimented with it, we tweaked it, and now Hybrid Chart is like a blaze going through our network because the physicians all tell each other Hybrid Chart works. The business people tell each other Hybrid Chart works. And so we have a strategic partnership with Hybrid Chart to roll that out. And I don't know exactly how many, but we probably have 25 of these natural experiments that are going on right now throughout the network. And as they're completed and as we learn from them, we can then develop a solution and offer that solution to all of the groups.
Did those 25 experiments all roll up to the innovation committee?
They do. They connect back to the innovation committee. They may have a clinical focus, they may have an administrative focus, an RCM focus, a research focus, but they're all experiments that we're working on, and they all lead to a decision should we partner with that one company?
Who's on the innovation committee?
So I can't tell you the names, but it's cardiologists and business leaders. And then we have some staff. All the committees have some of the NSO staff on them, but these are physicians, whether they're leaders or just rank and file physicians, but they have an interest in new technology, generative AI solutions like the hybrid chart solutions, which there are plenty of these one-off solutions. And most of what we're trying to do now is solve for problems without requiring groups to change their EHR and practice management system. We're very reluctant to see that happen. Our conclusion is most of the efficiency and effectiveness gains that we would like to see made in the CVA USA network can be made without requiring the physicians to change their personal workflow and EHR.
We get asked by CEOs a lot, how do you go about adopting technology? Because these are all complex ecosystems, they're delicate organizations, varying levels of receptivity to new technology and change. And it sounds like, if I were to sort of paraphrase, your answer would be don't fear experimentation, but put the right governance, put the right controls around the boundaries of that, the universe of that experimentation. Is that?
That's a fair statement. And as a result, kind of the fail fast mentality that we've seen work. Let's use these experiments to identify a good solution, or maybe a solution we think could be good, but we need to modify it in collaboration with a partner. And the partner has a motivation to help us. Why? Because they know if we could perfect this solution, it will be rolled out and touch 1.2 million patients. If we can't, then we're not going to be in this network at all.
What's the guiding principle for the innovation committee? Is it we are willing to experiment with new solutions that meet a certain threshold, either a certain amount of ROI or a certain meaningful improvement in patient care? Or is it come one, come all? If you have an idea, we're willing to experiment because we've got the right controls in place.
There, on the front end, there is a matrix that is used to score. So the innovation committee members themselves, which are business people and physicians, clinicians, they will score a potential solution up front to prioritize them. If it's a solution that we're interested in, but it's a low priority, then that falls into another category. If it's a solution we're interested in, but it's a high priority, but there are competing solutions in that space, all right, that's at a situation where we need to look for an opportunity to either experiment within our network, or in some cases, let's find other cardiology groups that have already done the experiment and then talk to them to see if we can filter out. So in most cases, it comes down to, is it an area that we need to work on operationally? If it's a low priority area and it only has a small benefit, even if it works well, the benefit is small in terms of maybe a number of patients or the ROI, let's take that off the list. Even though it may be fascinating and a bright, shiny object, let's take that off the list. Let's really look for high impact and high reward areas that we can implement and then experiment and curate from there.
So let's talk about risk-based reimbursement, value-based care. When we think about risk-based reimbursement, most of the time we're thinking about primary care, Medicare Advantage, maybe some bundled payments in orthopedics, but you've developed a risk-based model, specialty focused in cardiology. Tell us a little bit about how that came about. Was it an easy process to develop? Are you working directly with the payers or working through intermediaries? And how's it going?
Yep. So it is still a work in progress. I suspect if we were to have this conversation again in 5 years, I would probably still say it's a work in progress, because I think the frontier is so big. We have 1.2 million active patients, 30,000 of whom are in a risk-based contract, what we call lives under management. That's our KPI, lives under management. And we want to get more lives under management. And we've created several different categories of what qualifies as a life under management. It could be a bundled payment arrangement, which we have under contract with one payer, not Medicare, a fee for service, but one payer. Or it could be a total cost of care, not just total cost of cardiology care, but a total cost of care for lives we're managing. And that's what the Humana arrangement is that we announced on our website. It's a total cost of care, but on patients that are attributed to us. So it's very important, anybody listening to this, that we're crazy, but we're not so crazy as to go out and say, give us a total cost of care risk for a patient we've never met before. No. So we identified a big number of patients that are already being managed by our cardiologists, and according to Humana and our attribution model, they are attributed to us. They wouldn't even be attributed to a primary care physician. We're seeing the patients more than the primary care, more than any other doc. So that model, Jason, that's a sweet spot. We're very excited about this model because we believe we have a lot of patients who fit this category, that we're the primary physician manager for these patients. And what caused this, kind of back to your question, to come about is we knew that we could not achieve our financial performance goals, EBITDA, on the back of fee-for-service alone. Impossible. It's impossible. 15% of the cardiovascular dollar in the U.S. is paid to cardiologists. 85% is paid to hospitals, pharma, skilled care, whatever. Fundamental question: what business does CVA want to be in? The 15%, or the 85%, or the 100%? We want to be in the 100% business. We want to manage the whole spectrum of care, including even what has to be done in the hospital. So that's what put us on this path, believing that economically, because of such a high amount of care is avoidable and the cost of care is avoidable, if we could link our cardiologists with contracting and payers who are willing to contract, we could help them save money. But it's a narrow group of patients. So you brought up a point about primary care. That is the prevailing model because the vast majority of patients fit that model. The vast majority of Medicare Advantage lives or commercial lives, they would fit a model where the primary care physician can manage. Somebody educated me a few years ago, Jason, on the 10-80-10 rule, and it's played out, and I've actually played with it myself. 10% of patients are extremely healthy. The primary care doc could maybe see them once a year or once every 2 years, pat them on the back, talk about golf, the recent cruise, whatever. They're fine. 80% of the patients have a condition that the primary care physician, using guideline-directed medical therapy, maybe some virtual care and remote care, and wraparound interaction care navigation, they can manage those 80% just fine. But there are 10% of patients, whether it's a Medicare population or commercial life population, there are 10% of patients that are completely refractory to the interventions of a primary care physician. Once those primary care physicians who are taking risk realize this, and most of them have, they are very eager to find a specialty partner that they can say, all right, take all or part of those 10%, take the cardiology portion and manage that. And that is where we shine, is we are not asking them to offload the 10% healthy, the 80% that respond. It's the 10% refractory.
I was going to ask, so because you mentioned the Humana partnership, which is a direct payer relationship where you have attribution for these lives. And the question I was going to ask in follow-up is, are you working on partnerships with primary care groups that are offloading their cardiology patients? So, a coordinated way of working together.
So initially with the Humana lives, it's patients that are already attributed, that are named. So we actually know their names and we have them identified in our system. But particularly in Florida, where you have a lot of risk-bearing primary care MSOs in the state of Florida, we are working with those to help them identify part of that 10% that has not been offloaded or shifted to a cardiology practice and moving those patients over. We are careful about that because it has to be co-managed, it has to be collaborative. It can't be poaching. It can't be without the cooperation of the primary care group. But we've had some good success. Part of our risk-bearing contract model right now is with primary care. We publicly announced the one with InnovaCare, which has a lot of activity on the First Coast and here in Orlando where my office is. And so InnovaCare, we have a very collaborative relationship. We tell them, if you have refractory patients for cardiology, we're your partner. If you can manage them without us, keep them. Don't spend any more money. You've got it. The good news is for us, Jason, and for anybody looking at this, is there are a lot of patients who fit that refractory category. 10% of Medicare population, that's millions of patients that I think belong more in a specialty care model than a primary care model. I think even CMMI and Medicare Advantage companies, they realize that.
And I noticed on your website, you also announced a partnership with Prospect Medical Holdings. Is that a similar type relationship where you're covering their cardiology patients?
That's right. So this is one where it's a large IPA with, I think it's 40 or 50,000 covered lives. We've gone inside those lives with statistical modeling, our own proprietary software, and looked at those lives, and I've identified the ones that we think we can do. We can move the needle. If we can't move the needle, don't send them over. If we can move the needle, let's put them under our lives under management category. And then also, as I said, put us at risk. And we believe it's that risk part of risk-based contracting That's why I don't use value-based contracting or value-based much. I always say risk. It's the risk side that's the motivation for both the payer, the risk-bearing organization, us, our docs. Because without risk, what's going to change? Maybe nothing.
We always have this vision when we close our eyes of as the MSO market grows up and these platforms become larger and more sophisticated, that they'll start to work together. And the cardiology specialty will work with the urology specialty, will even work with the dental specialty, even though it doesn't seem related. And that will really elevate the care and the coordinated care holistically. It sounds like you're doing that. I mean, by extending into relationships with primary care groups, you're not just working with payers. And it sounds like there have been takers to the value prop that you've been offering. So that's encouraging.
We're in the early innings, but essentially CVA USA is setting up our ability to turn every one of our partners into a regional cardiovascular care management company with risk, and to connect with local regional payers or national payers that we bring in, that there are already lives in that market. The benefits of this are they're pretty simple as well. We can generate savings for the payer, better care for the patients, and income for us, but we can also show that we're a good partner. So if a primary care group is thinking about where should I send my cardiology patients, why would I not send it to my good channel partner? I want to send more to them.
Yeah, I mean, it sounds like a necessary criteria or component is the risk-based model, because you want to be able to move out of the 15% into the 85. And so when we think about risk, it's geographic specific. There's certain markets that are advanced in terms of risk-based models, and there are others that are further behind. Is the CVA USA model constrained by geography based on where these different states are in their adoption of risk-based models?
A little bit. I mean, I think New Jersey has a special set of requirements for any entity that takes risk for care outside of their own practice. So if it's within their practice domain, that's one thing. But if it's outside the practice domain for services that the practice doesn't deliver, there are certain requirements. But otherwise, the other 7 states, we don't have that same impediment. And we found great receptivity as we have good, high quality, easy access cardiology services in that market. We usually find within short order there are risk-bearing organizations that have an appetite for lowering their cost of care.
Have you thought about other types of strategic partnerships? So we recently did a podcast on direct-to-employer markets. Actually, you mentioned Orlando. This was a Disney case study that was in the Orlando market. Is that something that's on your mind, or any other types of non-traditional payers or strategic partner relationships you're focused on?
Yeah, so I think direct to traditional payer, then a sub part of that is where the payer is serving as a TPA for the self-insured market. We haven't opened that opportunity yet, but it's on our radar. And of course, direct to risk-bearing organization, risk-bearing primary care group. I think this employer market, and I think it can work, but just because of the disease, cardiovascular disease is more of a disease of the older. Mm-hmm. And I'm turning into the older. I'm 64 and a half, so now I'm part of the elderly population of the U.S., but it's a disease of the older. And if you look at most employers, when you look at non-Medicare spend, cardiovascular disease represents a fairly small portion versus the Medicare. So I suspect we'll always have more of an opportunity and a partnership with Medicare Advantage and Medicare fee-for-service, maybe eventually through some type of either ACO project or some kind of a demonstration project with CMMI. I'm very excited about the prospects of the cardiology community embracing a new technique and a new models for reimbursement, much like oncology did and nephrology, kidney did years ago. I think the American College of Cardiology, my former employer, I was the CEO of previously, I think they see the opportunity for the profession to move that direction, hospital employed or not. And I think individual physicians are realizing more and more, we can't stick our head in the sand. We can't just be work RVU generators, the prevailing model for cardiology. We have to generate value beyond just production.
Let's spend a minute on technology. Out of all these experiments that are going on through the Innovation Committee, what's been the most impactful technology that CVA USA has adopted, whether it's data analytics or AI or automation? What's been the best use case that you found so far?
Yeah, so maybe a couple. I think our digital command center is what we call it, or you could call it a virtual health center, this 24/7 center comprised of RNs and telemetry techs and others who are monitoring all of our networks, mobile cardiac telemetry currently. We had to come up with a platform solution. We wanted to be agnostic, Jason, to if a group wants to use a certain company's mobile cardiac telemetry device, fine. But that device, because of the standards that have been established for telehealth and remote health, digital health, the signals from that device need to go into a platform. That platform needs to be the virtual command center platform that can grab those signals, be able to monitor those signals, and maybe even apply some AI tools to know when a patient might be in distress. So I think that's a success story. We have established a single platform for receiving those signals and for all of those command center staff to be able to manage and monitor and then reach out to patients and reach out to their primary cardiologist when needed. So I think that one has worked well. I mentioned Hybrid Chart a few minutes ago. Hybrid Chart's an elegant solution. It's a rules-based engine that can be applied to any workflow where you're trying to connect A and B together. So I'll give you an example. Patient is in the hospital. Patient's going to be discharged from the hospital. You want that patient to have a post-discharge appointment and TCM that's connected in real time, and you want that all to happen without the cardiologist having to do anything but push a button. Hybrid Chart is that rules-based engine intermediary. There's an inclusion-exclusion criteria trigger. It recognizes the patient meets the criteria. The physician clicked the button to say start the process. And now into everybody's work queues that are affected by that, we now have communication in real time to those work queues about what to do. We've gone from patients leaving the hospital with no discharge appointments to a very high level, nearly 100% of patients that have discharge appointments. And those are also kind of stratified so that we know who are the patients who are more likely to have readmission problems. So now we have an elegant solution, not programmed inside the EHR. It's absent the EHR, but connected into the EHR, more or less a EHR embedded solution that the physicians, most of the time, they can use their cell phones to be able to interact with and communicate. So that's another great solution. The third one I would mention is we had to go shopping for a home-based cardiac rehab solution. And there are lots of them, but we had criteria for who we thought, what we thought functionality-wise would work best. We spent about a year looking at different options and testing different options, and we chose the one that we thought was the best one for our network, and that was a physician decision, and now we're rolling that out throughout our network. So we'll have one home-based cardiac rehab platform, one digital command platform, one hybrid chart platform for some of those post-discharge coordination of care efforts.
From a team perspective, what does it take to run the modern day MSO when you think about all the innovation that you're digesting in your organization? So one thing is the innovation committee from sort of a governance perspective, but what about from a IT perspective, from a AI perspective, from a quality and compliance and cybersecurity perspective? What are the areas of the org chart that other MSOs who are going to go through this should be thinking about building out muscles that have been neglected historically that are going to become more important in the evolving landscape?
Yep. So principles we have, and I'll take you through the committees and task forces that we have, but it must be physician-led. And it must be physician triggered. If we don't have Moses coming down to the mountain telling everybody what's going to happen, it has to be organic. All of our physician leaders embraced that we need to have committees of jurisdiction that will oversee and reinforce performance around certain areas. So quality is number one. And we put value with that. We always want to look for a way to define value from a clinical quality, safety, patient experience, access, equity standpoint. So we have a robust quality committee, a robust quality management system, including the first generation of a physician scorecard. So now we are actually issuing to each physician a personal scorecard, and it will get more robust over time because we all know the Hawthorne effect works. You just got to make it work. And without a scorecard and benchmark, physicians can't self-correct because they don't know. So quality committee, finance committee. Finance committee is very robust at CVA USA. We have a outstanding physician chairman of that committee and a lot of engagement around that. And we're not only looking at the financial performance of CVA overall, we're looking at each individual group performance. And even inside of that, we're looking at service line performance and RCM performance. So now we've got physicians who are holding each other accountable on financial performance at the group level, individual level. Number two. Number three, compliance. we have a great compliance function within CVA USA, supported a lot from Webster and some of our Webster sister companies that we've modeled our compliance function. But we've got a full-time, 3 full-time staff inside of CVA USA, plus a committee that does all things compliance, regulatory compliance, START compliance, fraud and abuse compliance, cybersecurity compliance, the whole kit and caboodle compliance that they're overseeing. The next one that I would point to as a big impact is our IT and innovation. We actually marry those together. I didn't mention that. So IT and innovation is one committee, all things data, all things AI tools, all things curating and identifying potential solutions. That's under the IT innovation. The next committee is ESG. So we have an active ESG, environmental social governance committee comprised of physicians and non-physicians that collects information, that has goals for each of the groups. And it's a big thing for us to make sure that we're improving our reach to vulnerable populations. We know in cardiology that there is an ACC published an article about this about 6 months ago. If you live in an urban suburban area, your quality of cardiovascular care is here. If you live in a rural area, because of access, it suffers, and mortality, morbidity, and outcomes suffer. So we're working hard through the ESG committee. Another committee we have is around our electrophysiology services. So the EP docs have gathered together to work on some EP specific areas of responsibility. We have a clinical research committee comprised of all of our research directors across the network. Generally, we have these pockets of jurisdiction that are physician-led, and when a physician or a physician group is not performing at the level that we believe is at the standard, it's the committee leaders or the physician leaders overall that then work on that. So the NSO team, the National Support Office team, even though we're supporting and we're helping to drive a lot of the growth initiatives, we're not the police, we're not the coach of the physicians. The physicians are the police and the coach of the physicians.
So from your comments, I have a sense of where you think the opportunities are in the market and how you've tooled your organization to succeed in the modern day landscape. What keeps you up at night? What are you worried about when you look at over the next, call it 3 to 5 years, maybe from a macro healthcare perspective, from a cardiology market perspective, and then from an operational CVA USA perspective?
I think from a macro perspective, I think we need the payers and the physician community to begin to standardize risk-based contracting models. We're in an early stage where there are some different experiments going on, different types of contracting, but I think we need a national codification. I think the ACC and Medicare and some of the big blues and BUCAs can help to standardize, much like what happened with kidney and oncology. So what keeps me up at night first is the lack of that means that we're doing these one-offs, bespoke deals all the time and trying to educate. Now, we will get momentum. We already have momentum. But this is a situation where I don't care if my competitors are doing the same thing. Great. We're all selling hamburgers. We're all selling fish. We're all selling French fries. Wonderful. At least everybody in the marketplace knows these are the products, and here's how the products work. So I think that's one. 2, cardiology is heavily dependent upon Medicare and Medicare policy, which means politics and elections and whims and winds blowing and whatever happens with the federal government. It's scary to think that your enterprise is completely dependent upon what is the prevailing policy or wisdom in DC. Does DC believe that private equity is the great Snidely Whiplash culprit for all bad things in the world? If they do, they go into an anti-PE mode. That's not good for us. Or do they believe actually, no, the truth is it's hospital control and hospital market concentration that has led to high costs, and let's go attack that. But it could pivot either way. I mean, we just saw it happen from one administration to another, almost a 180-degree difference in views. That's very scary. So I think those two together are some big risks that we face in this marketplace. Are we going to be able to realize our big dream of 200,000 plus lives under management, working with multiple types of risk-bearing organizations and payers and maybe employers? And are we going to have a Medicare program that is innovative and progressive and realizes we need to shift more care out of the hospital, more procedures to the ASC, more incentives for cardiology to manage populations and remove the avoidable costs?
It's interesting you mentioned about private equity. I started the conversation with my comments about CVA USA touching on the major themes in healthcare, from reduction in cost to improving access to differentiated care models, to strategic partnerships. How much of what you've built over the past few years gets done without the involvement of private equity from a capital perspective?
Zero. I mean, it's a situation. I look at this maybe in an odd way, but we have a very important capital partner, a group of capital partners. Those capital partners are highly informed healthcare partners. So it's not, even though we like to joke sometimes, it's dollars. It's not just dollars. It's important strategic guidance. And back to something you said, the ability to integrate pieces that are not cardiology with cardiology. It takes a big capital partner to be able to do that. So I always like to say we're building CVA USA on a chassis. The chassis was given to me. It's a good chassis. Do we have to make some modifications in style and this or that component-wise? Yes, but we're building on that chassis. We're building with the support of very smart healthcare investors, many of whom are physicians, by the way, and we're building in a way that fits a theme. What's our theme? Physicians driving the solution. That's our theme, a physician-first ethos, respecting the physician leaders and holding them accountable.
I want to end with a comment and a compliment. So there is something subtle about CVA USA, but I think it's extremely important, and I have a sneaking suspicion that you're a big driver of it, and that is transparency in terms of what you're doing. And when you go to the CVA USA website, it's different than a lot of other MSOs. It's, number one, very robust. There's a lot of tangible initiatives that are communicated on the website. Number two, it's very transparent. So you're out there publicly communicating what you're doing. You can see that in the news section. You can see it in the value-based care section. And number three, you're very clear on what your role is in the market, what your strategy and vision is, and you're very proud of it. And I think it really came across with a letter that you and your colleague published to the payer community recently. And I think it was probably on the back of your partnership with Humana, but everyone should go to the website and take a look at the letter. And basically it goes through what you've built, where you're located, and it's a call to the payers to work with CVA USA collaboratively. And there's a high level of accountability that you've assigned to CVA USA in that letter. You're willing to take a stand on the value you offer, and you're willing to put that at risk. And I think that is one of the clearest signs of leadership that I've seen. And we talk about, the role of private equity and how much risk there is in sort of getting it all wrong. And I really commend you on being as deliberate in that communication strategy. I think that's an important component of not just what you're building at CVA USA, but the MSO market, broadly speaking. And I commend you on that.
Well, thank you. And my personal philosophy is, in terms of competition, I love my competitors. I respect my competitors. I admire my competitors. Sometimes I even see something they're doing. I think that's a really smart way to do it. We should mimic that. It's okay. It's a big world. Only 1,000 or so cardiologists out of 30,000 cardiologists are part of a private equity sponsored PPM. We're all trying to do something generally similar, but we'll do it in a different way. And I learned a long time ago that there is a big difference between goals and plans and execution and sustainability. If good goals and good plans made for great businesses, we would have nothing but great businesses all over the world, because they usually have good goals and good plans. Where do they fail? Execution and sustainability. Sustainability being maybe the most important. Is what you're building going to last? Built to sustain. And so when I talk about CVA USA, I don't change my talking points for my audience. It's the same. I'm talking to our employees, same. Talking to potential groups or existing groups, same. Payers, risk-bearing organizations, same. Jason at scale, same. It's same. That's very important, because you create what you think is your message, what you think you're going to be good at. You tell people, you convey it, and then you close your mouth and go do it. And by doing it, you succeed.
Great note to end on. Tim, as always, fascinating discussion. Thanks so much for the time.
You're welcome, Jason. Take care.
Take care.
Bye-bye.